All right, so we are here at I almost said KetoCon. It's not KetoCon. Low Carb Denver 2023. Where are we? Yeah, we'll do a little beep out on that. Here with Dr. Jaime Seeman. So really excited to chat with you. And you've been talking about a couple things that are going on in your personal life related to like low carb dieting and cardiovascular health. I want to get into it a little bit, but I do want to ask you so far, what has been your favorite talk of the event so far?
I would say this morning we heard from Nina Teakoltz talking about USDA dietary recommendations and how they do not align with a large body of evidence for low carb and ketogenic diets. This information is being buried, it's being withheld from the general public, and it's time for us to speak up and demand that the science show, what we're seeing clinically, what I've seen clinically, and what people are experiencing in their lives right now.
Nice. Yeah, that one's really interesting because I remember when the dietary guidelines came out in 2020 and, you looked at the body of evidence they were presenting and if you looked at the evidence, you would say there's no way that they could recommend a plant-based diet. But then you got to the end where they actually make the recommendations and they recommended a plant-based diet. And it's like, but then we look at what we have on the low carb side and all this great evidence being presented at this conference and none of it's being taken into consideration. Did she give any sort of path towards, like, what is she acting? I know with the Nutrition Coalition, she has a lot going on. Anything new going on that she's doing to help progress that?
Yeah, so when we look over the last couple of hundred years, the changes in the American diet is an increase in carbohydrates. We're not eating more meat, although red meat has been vilified. We're eating more carbohydrates. So the U.S. dietary guidelines come out every 5 years. So in 2025, we should expect that the next set of guidelines is coming, and they're already starting to work on that even now in 2023. So from an advocacy perspective, what we're asking people to do is speak up. And in the last round where people could submit questions and comments, more than 70%, I think it was 77% of the comments asked for what is the review of the literature on low-carb diets. So we need to speak up. We need to demand this. Obviously, there's so much politics involved. There's so much money and special interest involved. And, we may not get our way in 2025, but what we can do is we can continue to just use our voices and spread the word and ask that the evidence be reviewed so that people can make a decision for themselves.
Yeah. No, that's really good. And I feel like, a lot of people, when you hear about these dietary guidelines, people who are kind of in the know about nutrition will say things like, oh, well, what does it matter? I know not to eat these things. But what a lot of people don't realize is that these are the guidelines that are used to shape what we feed our children in schools, what we give, our patients in hospitals, what's approved for low-income families who are on like nutrition support programs. So it's like the impact is actually great. It's even though we know not to eat what's recommended in those things, it has a pretty wide impact. And I think, the other thing is you look at the people on the board and all of them have some sort of industry tie or, tie to a pharmaceutical company. It's, it's like we need to get some of our people in there, right? We need to get some people who are, less tied to the industry and are more tied to getting people better results and progressing their health forward. So you mentioned red meat, saturated fat and everything, which is part of what I want to talk to you about today because you were talking about your husband, Ben, and what he's been experiencing and what he saw over the last 5 years. So I just want to tee that up for you to kind of tell that story to us because that's one of the most incredible things that I've seen. Like you always hear about these stories about people improving cardiovascular disease or you'll read in a book about it, but when you actually see it in somebody and then you see that this happened to them, what you're about to tell us, it's just mind-blowing. So what's going on with your husband?
Yeah. So when we adopted a ketogenic diet back in 2015, 2016, I was doing it because I had prediabetes and we both lost some weight. He got rid of migraines, his allergies went away. Of course, all this anecdotal evidence of how good we feel, right? But as a clinician, I had so many questions because for years in my training, I was taught that the biggest risk factor for cardiovascular disease is LDL cholesterol. So what we're finding now, and this is, of course, there's a lot that's come to light than what I knew back in 2015, 2016, is that there are other tests that we can use, like coronary artery calcium scores, to risk stratify patients that have high LDL. Now, I will tell you that he and myself were not the people that their LDL cholesterol shot up on a ketogenic diet. So we both had normal lipids, but we were still very much interested in what our risk was because, of course, you hear people say, if you eat beef and eggs and butter and bacon, you're going to clog your arteries. And so we wanted that data starting so early in this kind of what I would call a dietary intervention for us. What is our baseline? So here we were in our mid to late 30s. We thought, let's go get a coronary artery calcium score because most people don't get this scan until they're 50. Generally, when women are menopausal and you have more risk factors and you've had 20, 30 years for atherosclerosis to build up. So we skip off to get our scans 4 years ago, assuming that they would both be zero. And mine was, and his was not. Now, a background on him is that he does have a strong family history. He had a grandfather that dropped dead of a heart attack at age 52. And so he gets this scan, and his score at the time was 186, which for him is in the more than the 95th percentile for his age. Very scary, very eye-opening for us. And now we're trying to navigate what to do about it, because the recommendations by the medical body at that time was intensive statin therapy, aspirin therapy, lifestyle intervention, but he was already doing a lot of that, and his lipids looked normal, and he really looked healthy, Yeah. So what do you do with this information? So he chose to not treat with any sort of medications. He did initiate vitamin D3 and K2 therapy, which we know that calcium metabolism is very much involved with vitamin D, vitamin K2. And so taking a vitamin D3, K2 supplement, or getting adequate sunlight is great, getting dietary K2 is great, but we doubled down knowing that he had calcified plaques. So he took it about 5 out of the 7 days of the week. We're not perfect, can't remember every time. And we decided we were just going to repeat the scan in about 4 to 5 years, because what we know about coronary artery calcium is that the progression of disease, the rate of progression of disease, is actually what's most important in trying to identify people that are going to have an event. If you have coronary calcium and it's stable and that score stays the same, 5 years later, 10 years later, you're doing great, right? You're not throwing any kerosene on the fire, the proverbial fire.
Yeah.
And so, and mind you, his glucose was normal, his fasting insulin was normal, because we had been ketogenic for about 2 years at the initial scan. So we just recently repeated his scan. It's been 4 years since his initial scan, and we didn't know what it would show. We didn't know if it would be double or triple. What if it was the same? This really was like an N of 1 study for us, and we were both very nervous about it, to be blatantly honest. But he just got his scan done, and his score is 0. Which it was 186. And, there have definitely been people who have said we've seen reversal or lowering, because when you're doing a scan, it's depending on the radiologist reading it. There could be some inaccuracies in humans, reading the test. But 0 is 0 is 0. There was no identifiable coronary calcium, which is quite incredible, because even the doctor that developed the CAC score, Dr. Agassan, has said it cannot be reversed. You cannot pull the calcium back out. Of course, from my perspective, if you can lay down calcium in bone, you can pull it back out. But Dr. Ivor Cummins was here talking about how these are calcium crystals. It's not like bone. But then I ran into a pathologist here that said, no, we've seen bone formation within these arteries, which would lean towards the ability to pull the calcium out. So we will be getting something called a CCTA, a coronary angiogram. So we actually put dye into the arteries to look to see if there's any soft plaque, because that is now the question is there soft plaque? And soft plaque is more unstable. It's actually more dangerous than calcified or hard plaque. So this is kind of the next step in this journey, but we're very interested in possibly writing a case report on it or a case series if we can find other patients. But here at Low Carb Denver, I was able to listen to a few different presentations, one of them from Dave Feldman, who is studying the lean mass hyperresponder population. And what Dave is finding out is giving me a lot of reassurance with what we're seeing with my own husband. And hopefully will give us a lot of information for the future about how we can talk to our patients that are on low carb and ketogenic diets who experience an isolated increase in LDL cholesterol, but have a great HDL and a low triglyceride number and normal fasting glucose and fasting insulin, because that is the looming question in the low carb community is, does that increase your risk for cardiovascular disease? Because of course we don't want to feel great and then still drop dead of a heart attack. We really care about the long-term outcomes for these patients and for ourselves.
Yeah. No, that's amazing. I mean, it's one thing to show a dietary method that doesn't make things worse, but to see it reverse something that was previously thought to be unreversible is incredible. I'm curious, so, you did the first test with Ben 2 years after you, about a year or two after you had started keto, and then 6 years later, so 4 years in between the two. Was there a big difference in his keto diet in the first 2 years versus the last 4? Or do you think that if you would have tested before keto, it would have been even higher than what you saw at the 2 year mark? Or do you think it was the D and the K that was helping make the big difference? Yeah.
Yeah, I think it's hard to pinpoint exactly
Right.
what it was, but we know that the difference was right around the time we got these CACs, we were hearing more about the carnivore diet. And we did really transition our ketogenic diet into a much more meat-based diet. So exactly eating the things that they tell you not to eat: red meat, eggs, butter, occasional bacon. He's not completely carnivore. He does have avocado. He may have, other plants here and there, but I think it's just interesting. Right around this time, we did transition to a very much carnivore-based diet, which most people in the cardiology world, their heads would spin eating that amount of saturated fat. But he was exercising, he was lifting weights, he was trying to sleep well, he was de-stressing, he was using red light therapy. We added D3K2. So I think it will be difficult to, pinpoint that it was one thing. I really honestly think it's a culmination of those things. It's something that I talk about, the 5 pillars: what you eat, how you move, how you sleep, how you deal with stress, and the rest of your environment. And I think it's an all-encompassing approach. It's not just one thing. You can't just focus on one thing, and the body's so complex. But I think this is really giving us a lot of answers about LDL cholesterol, and really it will turn lipidology on its head, when this comes to light. And hopefully our medical community is open-minded to this idea, but there is a growing number of patients that are attempting low-carb diets. We're seeing metabolic therapy for patients who don't have a choice. They have epilepsy, they have schizophrenia, they're uncontrolled type 1 or type 2 diabetics. It's great that we have a choice in the diet that we can eat, but there's a lot of people that don't have a choice. And so we need to be able to tell these patients what their risk really is.
Yeah. No, I mean, that's huge. And you talk about like flipping the world of like lipid metabolism on its head. It's like right now we live in a society where the most commonly prescribed medication is statins, and so many people are on them, but the outcomes are not great from it. It's not, if you look at like the raw data on these studies looking at statins, we're not seeing an extension of life from these things. And as we were talking about this before we were recording, there's a lot of downsides to taking these statins as well. So it's like the current treatment options are not working. They're actually making these people far worse. So, and maybe not everybody would agree with that. I think there's maybe a time and a place for statins. I think we've, even within this conference, we've seen doctors with differing opinions on that. But the fact of the matter is most people aren't getting better from these medications. So having a different and alternative method, I think, is huge. So for anybody listening to this who, they've been following keto for a while and they're really interested in getting some of these tests done, what does that look like? Is this something that you have to pay out of pocket to do? Can you go ask your primary care physician for this? Or what's kind of the approach to getting some of these tests done?
Yeah. So if you're sitting at home and you're somebody that is worried about your long-term metabolic risk, you want to lose weight, the one thing that's been very clear is that lifestyle intervention gets better results than any drug. Any drug. We have seen that time and time again. Drugs definitely have their place, but they come with their own risks too, and risk of side effects. So the first thing you should do is get baseline lab testing done. So you go talk to your doctor, you ask for an advanced lipid panel. It comes with a lot of different names depending on what lab you're using, but an advanced lipid panel that has more than total cholesterol, LDL, HDL, triglycerides, and VLDL. It's going to have things like ApoB or Lp(a). And these are newer markers that we think are probably more important to look at than isolated LDL cholesterol. So ask for an advanced lipid panel. It's a fasted test, 12 hours fasted to do the test. Also, because you're fasted, ask for a fasting glucose and a fasting insulin. You could look at other markers like high sensitivity CRP. You can get a CBC or a comprehensive metabolic panel added onto that. These are really basic labs, and they're really not that expensive. They should be able to be ran through your insurance if you have insurance. Then what you do with that information is you look at, what your body composition is, what your blood pressure is, what all of these labs show, and then what you're experiencing. Do you have migraines? Do you have fatigue? Do you have, what are the clinical symptoms? And you put that all into a comprehensive plan that starts with diet, movement, sleep, stress, and environment. Now, the coronary artery calcium scan is a newer test, but it's a cheap test, and that's the greatest part about it. It's widely available. Any place that has a CT scan can perform a coronary artery calcium scan. A lot of times insurance actually won't pay for it, but in all across the US, it ranges from $50 to maybe $150. So it's not an expensive test, and it's not something that you repeat, time after time after again. You want to look 5 to 10 years down the road if you're repeating this kind of test. But we've heard from cardiologists here that there is a power when that score is 0. If it is 0, that is very, very, very reassuring. And if it's not 0, then you start plugging yourself in with experts that can help decide, if there are other tools that need to be added, like statin therapy or other medical therapies like high dose omega-3 fatty acids. There's other tools because we all have different genetic risks. And a lot of this LDL cholesterol research comes from what we know about something called familial hypercholesterolemia. So this is like very young children that have sky-high LDLs that are having heart attacks, having strokes at very young ages. That is where LDL really became the villain. And now what we're finding is in those patients, they have altered lipid metabolism. In a normal person with normal genetics that just has isolated LDL and has normal lipid metabolism, it may not be the same thing. So we're all different. We all come from a different genetic background. So get your labs tested, talk to your doctor, advocate for a coronary artery calcium scan, and know your numbers. Test, don't guess.
Yes. No, I love that. And I feel like it's such a, that actually is a lot different from what's currently going on. A lot of times you go in, you get just a couple markers looked at, and then you're getting, prescriptions or, recommendations based off of these single markers. And as you highlighted, all of these things are really important. Like, just looking at LDL by itself isn't enough. Even just looking at just the particle size by itself isn't enough. You have to be looking at a lot of these other factors to really get a full picture of health. You also had mentioned the soft plaque. So you're getting a follow-up test done with Ben on that. What does that test look like? Is that something that you can get done anywhere? Is it cheap? How do people go about getting that looked at?
Yeah, so a CCTA or coronary artery, CCTA is a CT angiography. So this is a little more invasive than a coronary artery calcium scan. A CAC, you lay in the CT scanner. It's a really quick, less than 5-minute test, a quick CT scan of the heart. With a coronary scan that does angiography, they do have to start an IV. They have to use a contrast dye. So they insert the contrast dye, it goes into the coronary arteries. They repeat that quick little CT scan while the dye is circulating. And it gives a different picture because it's filling the vessels with dye. And so it allows us to see if there's soft plaques. They can actually see where the calcified plaques are and where the soft plaques are. And so this allows us to see what we call the total plaque burden. And so in our situation, the question will be is if you have decalcified these plaques, is there soft plaque there? Or has there been complete regression of soft plaque? So this will be the next step for us in kind of figuring out what his risk is. And for anybody out there, it a lot of times is the next step when you see your cardiologist. They'll do a CCTA, they'll look for soft plaque burden because that if you have soft plaque, that still increases your risk long-term of having an event. So there are people that can be fooled. They can have a 0 CAC and still have events. There's always outliers to these things. But it's important to just know what your risk is so that you can try to do something about it.
Yeah. So in the event that comes back and that number is high, he has more soft plaque than what you were thinking, do you have a method? What would you do next? Do you know, or would you seek then, help from a cardiovascular specialist, or what would be your approach?
Yeah, I think you have to lean on the experts here because it's definitely not the area of medicine that I practice in. But I think the question also is, what we would naturally see with decalcification is that soft plaques could remain and then there could be regression. And so this is something where you look over time. So, it's hard to say what things look like 5 or 10 years ago for him, for any particular patient. So it's something that you monitor over time. And once again, modifiable risk factors, right? You can't modify your genetics, but you can modify what you eat and how you move and how you sleep and all the things that we've reiterated 1,000 times, because those things do have way more impact than any drug or any other intervention.
Yeah. No, I love it. That's great. And I appreciate the breakdown for it too. I think this is one of these conferences where we get to be on the forefront of new information that's coming out. And that's something that's always been the case with these because we're in an industry where what we do here isn't as widely adopted across the rest of the medical community. Things are a little bit more fringe, you could say, with some air quotes. But we get to see this really exciting research presented by folks like Dr. Feldman, or not Dr. Feldman. I always want to say Dr. Feldman because he seems like he should be a doctor. He should have an honorary degree, Dr. Feldman. But yeah, I think it's really cool to get to be on the forefront of that. So you're talking tomorrow. What is your topic tomorrow?
Yeah, I'll be talking on metabolic health for women, and it's a much different lens than many of the people at this conference look through on most days, because women in particular are more complex than men. We have a menstrual cycle, we're reproductive creatures, but a particular hormone called estrogen, which is not the dominant hormone in women, testosterone is, but estrogen plays a huge impact on our metabolic health. And when we have loss of estrogen at menopause, it changes mitochondrial function, it changes our our metabolic risk, and our risk for all the things that women die of, heart disease and cancer, starts to skyrocket. So this is where nutritional interventions can be really helpful. Sometimes hormone replacement therapy can be an added tool to our toolbox as well. So I'll be talking about the risks that women in particular are susceptible to over their lifetime, and how pregnancy is really a window into future metabolic risks.
Nice. No, that's great. And for anybody who's really curious to learn more about that topic, if you scroll back a few episodes of the Thinking Health podcast, you'll see the episode that I did with Dr. Jaime where we covered a lot of that stuff. And that was one of those really eye-opening episodes for me where I learned a lot. It's been really fun now to even just to get to engage in conversations more. I remember after that podcast, I went inside immediately and was talking to my wife about it. I was I learned so much from Dr. Jaime. I have to share it with you. But yeah, I'm really excited to see your talk tomorrow and really appreciate you coming on and talking to everybody. Yeah, I think this is just one of those awesome events that we get the luxury of leaving feeling really excited and empowered from it. So yeah, I really appreciate you coming on and chatting.
Yeah, my pleasure.
Yep. Cool. Thank you. Great work. Give me some.
Oh.
Let's go.